Good morning. I am Leslie Luther, Executive Director of the American Red Cross of Northwest Illinois. We are grateful to you all for joining us to participate in this conversation about sickle cell disease and why Black donors are needed. Our special guest speakers today are Dr. Yvette Miller, Dr. Kyle Mack, and sickle cell warrior Robin Newsome. Before we begin, here are some housekeeping rules. To enhance your meeting experience, we recommend that you set your screen to speaker view using the button in the upper right-hand corner. We will be taking questions following the presentations by the three speakers. As you think of questions, please place them in the chat box. We will be monitoring the chat and will present your questions to the speakers at the appropriate time. This session is being recorded. Our moderator today is Lisa Bagley, Senior Vice President, Pharmacy and Retail Operations for Walgreens. Lisa also serves on the Board of Directors for the American Red Cross of Greater Chicago. Take it away, Lisa.
Thank you, Leslie. Sickle cell is the most common genetic blood disorder in the United States. There are about 100,000 people of various racial and ethnic backgrounds living in the United States today with sickle cell. And although most of them are of African or Latino descent. There is no cure for sickle cell, but the Red Cross supports one of the most critical sickle cell treatments of all, blood transfusions. For many patients, a close blood type match is essential and is found in donors of the same race or similar ethnicity. This discussion today is about the importance of developing and maintaining a diverse blood supply to help meet the unique needs of people with sickle cell, a genetic disorder that disproportionately impacts Black communities. Our first speaker today is Dr. Yvette Miller. Dr. Miller is the Executive Medical Officer for the Donor and Client Service Support Center for the Red Cross in Charlotte, North Carolina. She has been with the Red Cross for over 24 years, and she's been serving in various leadership roles, including Regional Medical Director and Director of Apheresis Donor Collections and Clinical Services for the Arizona region. Dr. Miller?
Make sure, that I'm not, can you hear me?
Yes, we can.
Yes, okay, great. I need to turn on the microphone sound. So thank you so much, Lisa, for that introduction and this opportunity to share some information and some insights about sickle cell disease and the transfusion needs of patients with sickle cell disease. So I'm gonna start out talking about just a little bit about sickle cell disease. You know, our next guest, Dr. Mack, is going to cover sickle cell disease a little more in depth. So just the basic information. So sickle cell disease, again, as you already mentioned, is a hematologic condition where the red blood cells, based on the genetic abnormality, the red blood cells change shape. And when these red blood cells change shape from their normal disc shape biconcave, which means they have two little sunken areas on each side where they carry the oxygen, when they change to the C shape, then they lose their ability to flow freely through blood vessels. And so that's when they start to block up blood vessels. They attach to each other, they attach to the walls of the blood vessels, as well as stimulate an immunologic and inflammatory response, and that leads to a lot of the complications of sickle cell disease. And so then as those cells break down, of course, that's what causes the anemia. So we used to refer to sickle cell disease as sickle cell anemia solely, but now we know it's a constellation of symptoms, so it's identified now as a disease. So I'm going to focus on sickle cell trait. So sickle cell trait is the, again, genetic abnormality that a person is born with. And when two individuals have a child and both of those individuals transmit the trait to a single child, then that's when that child will have sickle cell disease. But in every single state in the US, and the testing for trait is mandatory at birth. And even though I think a lot of people believed that the testing for sickle trait has been mandatory for years, but beginning in 1987, it was only a recommendation. It became a mandatory statistic that all states needed to keep on May the 1st of 2006. So only since 2006 has it been mandatory for every state to test children and to test babies and collect this data. And so many people who were tested years and years and years ago, they don't even know what their status is. And so that's really one of the problems, or one of the issues that leads us to continue to have people that develop sickle cell disease, is that people do not know their status. And so because you don't have to be, as has already been mentioned, African American or Black to have, or from a community of color to have sickle cell disease, sickle cell trait, everyone should be tested. And that testing, of course, can be done through your healthcare provider. At the American Red Cross, we don't test every individual, every donor for sickle trait. Under certain circumstances, we do test specific donors at the request of our hospital customers to do testing for sickle trait. And as we build our inventory to meet the transfusion needs of sickle cell patients, we do routinely test some of the donors, but we don't test every donor. So it's always best, as part of your own health care and health and welfare, is to find out what your sickle cell status is. So just a little more about sickle trait is that, so sickle trait is endemic in countries all over the world where malaria is endemic. So having sickle trait is actually an evolutionary adaptation to prevent a person from acquiring malaria. So that's why people in sub-Saharan Africa, in regions of South America, the Caribbean, Saudi Arabia, India, and the Mediterranean have people in those populations have sickle trait, because those are areas where malaria is endemic. Okay, so I'm going to go on. So I posed some questions. So then one of the questions that is, how has the coronavirus pandemic affected African American community? Well, we all know that because of the high prevalence of chronic conditions in the African American community, specifically in communities of color in general, hypertension, heart disease, lung disease, diabetes, the presence of those chronic conditions predispose people to acquiring the infection with COVID-19. So the African American community has absolutely been hit hard. And so because of that, the number of African American donors that have presented to donate in March and April plummeted by 50 to 60%. So the only saving grace was that the hospitals weren't taking in as many patients, they weren't having those elective procedures, but patients with sickle cell disease still needed their transfusion therapy. So hospitals did adapt, and they sort of stretched out the time between the transfusion episodes for the patients. So it was really a struggle to meet those transfusion needs. While the number of African American donors that has increased, we are still struggling to meet the transfusion needs of patients with sickle cell disease. So why is it important for African Americans to donate for patients with sickle cell disease? So African Americans have a very diverse genetic pool, so such that when there are patients that require repeat transfusions, we just can't take any unit of blood off the shelf and expect that unit to closely match the cell type and the antigens on the cells of patients with sickle cell disease. So some antigens are unique to African Americans. There's a red cell phenotype called Duffy A negative, B negative. And essentially, African Americans are the only population that has this phenotype in any high proportion. And the majority of the donors in our donor pool, and this is not just unique to the Red Cross, it's all over the United States. The majority of donors in the donor pool are Caucasian. So upwards of 85% of the donor pool is Caucasian. And so to try to find a unit of this Duffy A negative, B negative blood in the Caucasian population is extremely, extremely rare. So for situations like this, that's why we need African Americans to donate, so we can find the blood that we need to match our patients with sickle cell disease. And so what can we do to encourage and support blood donation by African Americans? So the Red Cross has done some surveys to find out what is important to the Black community in terms of understanding why it's important to donate blood and how we can best serve the community. And some of those issues are the Red Cross needs to do, and all blood collection organizations need to do a better job explaining the connection between African American blood donors and the need for sickle cell patients, like I just did with that example about Duffy A negative, B negative blood. We also need to make it convenient for communities of color and the African American community to donate. We don't have as many fixed site locations in the African American community, and so it can be inconvenient to find a walk-in site to do a donation. While now during COVID-19, every donor has to have an appointment, so we don't take walk-ins, we still need to think about and make it convenient for people to come in to donate. We need to partner with those trusted organizations and those trusted sources in the African American community, churches, sororities, fraternities, social groups like the Links, and Jack and Jill, and sororities and fraternities like Alpha Kappa Alpha and Delta Sigma Theta. I'm a member of Delta Sigma Theta Sorority Incorporated, and so Reach and Omega Psi Phi, and I see on the opening shot there's some Omegas that are donating. So definitely partnering those kinds of organizations are really important to encourage and support and increase the knowledge of the need for African Americans to donate. And in terms of our faith-based organizations, when we interface with churches, in making sure that the pastor is able to spread the message. So we really need to coach the pastors and the thought leaders and the respected individuals in the church about what the messaging is. And so if a pastor donates blood, or a pastor's spouse, or other respected members of the church donate, you can better believe that that's going to probably be a very successful blood drive, because that's the community. The churches are a community resource, and people love to participate and support their churches and their faith-based organizations. So I'm going to stop right there, and I'm not going to take questions. I think we're going to take questions at the end. So I'm going to stop right now, and then I'll turn it back over to you, Lisa.
Okay, thank you so much, Dr. Miller. Our next speaker today is Dr. Kyle Mack. Dr. Mack is a pediatric hematologist at the Ann and Robert H. Laurie Children's Hospital of Chicago, and an assistant professor of pediatrics at the Northwestern University Feinberg School of Medicine. He's on the board of directors of the Greater Chicago Red Cross and chairs the Biomed Committee. Dr. Mack?
Thanks, Lisa. I am going to share my screen and just run through a few slides. So this slide just highlights the basic pathophysiology of sickle cell disease. And you can see that these are normal red cells, these are sickled red blood cells, and there are conditions that can lead to increased sickling in patients that have a genotype consistent with sickle cell disease, so that instead of these biconcave disc-shaped red cells, you can get a preponderance of sickling. And if you get significant sickling, you can get decreased blood flow to vital organs, which can manifest with acute and chronic complications. So how common is sickle cell disease? We know that 1 in 12 African Americans has sickle cell trait. 1 in 500 African American newborns has sickle cell disease. And when we talk worldwide, there are about 300,000 babies born with sickle cell disease each year. In the United States, we believe there are about 80 to 100,000 Americans living with sickle cell disease currently. As Dr. Miller mentioned, sickle cell trait, if in this illustration, if you take two parents who each have sickle cell trait, each time they have a child, they'll donate one allele. And so you can see here that both parents can donate A alleles, which would be normal hemoglobin. One parent can donate an S, the other parent can donate an A, the other parent can donate an A, and the other parent can donate an S, or both parents could donate the S alleles, which would result in the most common type of sickle cell disease, which is hemoglobin SS. This slide illustrates that every organ is affected. So retinopathy, or the eyes, can be affected with sickling. You can have problems from a cardiopulmonary standpoint. You can have problems with your spleen, pain in your bones, skin ulcers, liver problems, kidney issues. So no organ system is really spared from sickling. Well, when we talk about transfusions can be indicated for acute complications, but also chronic long-term complications as well. And so you can see here, I'll just highlight that patients who present with acute anemia or concern for stroke or bad pneumonias might have an indication to receive an intermittent transfusion or a one-time transfusion. And there are patients who have complications from their sickle cell disease that can result in heart failure, can put them at increased risk for strokes, patients that have frequent pneumonias or chronic pain, and these patients need blood transfusions approximately every month. When we think about blood transfusions in sickle cell disease, the majority of patients with sickle cell disease will receive more than one transfusion in their lifetime. Most will receive at least one red blood cell transfusion by the second decade of life. Children who have complications of stroke with sickle cell disease will need anywhere from 15 to 25 units of blood each year indefinitely. 25% of patients with sickle cell disease may develop these immune reactions, which Dr. Miller spoke to donor red cells that may make it difficult for patients to respond to transfusions. And so our goal is to optimize the blood product for children and adults with sickle cell disease so that they can receive the best antigen match blood to avoid this issue of developing these immune reactions and potential resistance to blood transfusions. So as I mentioned, children with sickle cell disease will require many transfusions over a lifetime. 25% of patients will have these immune reactions to donated red cells, and we're looking to find the best antigen match blood for children to avoid this problem. When we think about the potential benefits of African American blood donors, specifically for patients living with sickle cell disease, in the United States, African Americans make up about 12% of the general population, but less than 1% of those who donate blood. Many of the factors that are important for matching blood are inherited, and blood donors from the same ethnic group as the child who needs blood are likely to have similar blood profiles, and this will lead to fewer blood reactions. We started a unique program here at Ann Robert H. Lurie Children's Program in partnership with the Red Cross, where we go out into the community and recruit African Americans to donate blood for children with sickle cell disease. And we started the program because of the discrepancy between people who donate blood and the small proportion of African Americans who are part of our donor pool. So how can we help? How can you help? You can sponsor a targeted blood drive. You can encourage family and friends to become regular blood donors. We can ask our large employers or civic groups to schedule blood donor drives. And roll up your sleeve and give personally. And I'll just highlight a brief anecdotal story. Because of our unique partnership with the Red Cross and our blood donor program, as I mentioned, African Americans who are donating blood with the Red Cross can earmark their blood for a child with sickle cell disease. I, as a pediatric hematologist who takes care of children who have blood disorders, started routinely donating blood as a part of this program. And so I donated blood, and about a month later, I got a notification on my Red Cross app that told me that my blood made it to a patient. That happened to be a week when I was on service taking care of inpatients in the hospital. And about maybe 10, 11 o'clock in the morning, we made a decision to donate blood for, we made a decision to order blood for a patient who had a complication from their sickle cell disease. And as I mentioned, the blood that I donated earlier in the month had made it to a patient. And so it's very likely that since I was participating in our unique blood donor program, and my blood that I donated was earmarked for a child with sickle cell disease at the hospital that I work at. That in this case, it's possible that I ordered my own blood for my own patient. And so this just highlights the importance of making sure that we're all doing our part and rolling up our sleeves and giving. So I'll just finish with these take-home points. Children with sickle cell disease regularly need blood. Blood from other African Americans is likely to cause fewer serious blood reactions in children with sickle cell disease. In order to support our children with sickle cell disease, more African American blood donors are needed. And community partnerships are an important linkage to increasing awareness and participation. Thanks for your time.
Thank you, Dr. Mack. I love that story. I've heard you tell it a couple times about possibly ordering your own blood. It gives me goosebumps every time.
Yeah, I know.
Thank you for sharing that with us.
It's a great story.
Yeah, it's awesome. Our next guest today is a sickle cell warrior, Robin Newsome. Robin was born with sickle cell, and she says that living with sickle cell has impacted every aspect of her life, growing up, going to school, and her work life. And here's Robin to tell us her story.
Hello, everyone. Thank you guys for having me as a guest speaker today. So I'm going to tell you a little bit about myself. Like you said, I was born with sickle cell. My mom didn't find out until I was about 2 years old when I had my first sickle cell crisis. She was getting me ready for church. She didn't know why I was crying. I just kept crying and crying and crying. And anything that she did, it didn't help. She couldn't soothe me. So she decided to take me to the hospital and found out that I was in a crisis and I definitely had sickle cell anemia. So at that time, my mom was a young mom. She was about 17 when she had me. So she quickly had to learn how to care for me. And from that point, I was in and out of the hospital about 3 to 4 times a month. So I'm sorry. So I can remember having a crisis and my mom running and putting me in like bath water, hot water. She would run hot water and try to soothe my pain because I was just screaming and there was really nothing that she can do. Sometimes the hot water helped and sometimes it didn't help. So I would end up back in the hospital needing blood transfusions, and I've had so many blood transfusions to the point of iron overload. So I had to take a medication for that to bring the iron down and things like that. So I can remember one particular time I was turning 16 and I had a sweet 16 party planned, and I was excited. I was excited about the party. All my friends was coming, my cousins were coming, and I ended up sick. The party continued, but I was on the couch in pain. Everybody was running around having fun, and I just had to just sit there and watch them enjoy my cake. Sometimes I get sensitive talking about it, talking about a lot of my sickle cell issues, but it's part of my life, and I learned to live with it and and push through the pain, push through the problems that I have. As some of the doctors have mentioned, some of the complications of sickle cell, I have developed acute chest syndrome, pulmonary hypertension, issues with my eyes. So I try to keep on nice frames. I can't see without them. So a lot of people like to say that I'm resilient, strong, or warrior, when most times I feel defeated, weak, and scared. Excuse me. But I try not to complain about the issues that I face. And I just know that God is on my side. So I continue to push through. I'm sorry. Sorry, guys. So I continue to push through and try to live the life that I can live, you know. I have some friends that totally understand what I go through, and then I have some that don't. So sometimes I try to push myself to accommodate others, and sometimes I just can't do it. So sometimes it consumes me. And I'm getting myself together. So sometimes it consumes me, and I just have to just pull back and try to regroup and get things together. So I can remember another time needing a total blood exchange. I can't remember the proper name for it, where they had to remove all of my blood and give me new blood because all of my cells were in a crisis. So it was kind of like, it looked like a dialysis machine. They used this huge machine and they just replaced the blood to make me feel better. The way that blood transfusions have helped me is tremendous. Like, I can feel instant relief once I get a blood transfusion. My color, my pain is better, my color is better. And I'm just grateful for the people that do donate. If I can say anything to any of my friends that's watching or anything, roll up your sleeves and give. It helps. It helps not just me, but it helps other people that really needs it. So I just want to thank God for those people that do give, that do give the blood. And I'm looking to like help sponsor maybe a drive or something like that. And to get the word out to help other people. As far as work and school, if I can go back, I'm sorry, I skipped over some things. If I could go back, I missed lots and lots of days of school. I had to repeat a grade just from missing school, from being in the hospital 3 to 4 times, 3 to 4 times a month back, when school was in. As far as work, I have an awesome job. I work in pediatric dialysis, and I have a boss that understands, what's going on. So sometimes I can miss 5 days, I can miss a week, I can miss 10 days, and I still have a job after that. So I'm grateful for that. Any questions for me?
Robin, I just want to say thank you. Thank you for sharing your story, for being so real today, and letting us see and better understand the personal journey that you've been on. And I know there are a lot of comments coming in as well, thanking you for sharing your story and talking about the strength you've shown today and how powerful your message is and what a difference it's going to be able to make for many, many people out there. So truly, thank you for sharing. And thank all of our speakers today for the stories you've shared, for the information that you've shared. We greatly appreciate the message that you've given. So Robin, we'll give you just a slight break, but we're getting ready to transition to the questions. So now's the time that we've set aside for questions, and we want to start with the questions that have been entered into the chat box. So we will read those questions for our presenters to be able to respond to them. And when we've cleared those questions, if you have additional questions, please feel free just to unmute yourself and go ahead and ask the questions. So again, I'll turn it over to the open Q&A forum.
This is Leslie. Dr. Miller, one of the questions in the chat was if you could talk a little bit about why African Americans don't give as much as other groups.
Yes, thank you. So when I have this conversation, and again, people will volunteer when I host blood drives all the time through my sorority. And so, when you're inviting people to donate, they say, I don't like to get stuck by a needle, and, and rightfully so, they will say that my hemoglobin is low because for African Americans, our normal physiology, our normal hemoglobin is on the lower end of the scale. So, having a low hemoglobin absolutely is a legitimate reason that people have been deferred. But I do encourage people to, have a conversation with your doctor, talk about your hemoglobin and what you can do to improve it. So I do encourage them to share that information with their healthcare provider. So, one of the things that, and again, having, lived my entire life in the African American community, I understand the reluctance. the African American community, like every community, but the African American community is more solely impacted. There are multiple competing priorities for our time and our resources, both our external resources and our personal resources. You know, time to donate, you know, between all the other things that you do. You know, many people in the African American community have, you know, multiple part-time jobs and other obligations, and it might be more difficult for the African American community versus some others to find that free time, that leisure time, which a lot of people use to donate, to find that time to donate in that way. So it can be a challenge to find the time. And in the African American community, blood donation is important to us like it is everybody else. But again, because there are other, you know, community priorities that can take precedent, it won't be at the top. For many communities, it won't be at the top. So, and then a lot of people do not understand, as both Dr. Mack and I have emphasized, you know, the connection, the direct connection and the genetics between, you know, African American donors and African American recipients, particularly for sickle cell disease. So it's our responsibility to make sure that the community understands that you hold the resource. Your blood is literally and figuratively the resource that can support and save the lives and prevent the complications of patients with sickle cell disease. So, you know, the better we get that information out and make it clear what that connection is and what that blood that we donate does to save people's lives. You know, like Dr. Mack talked about his story, you know, that it could have been his blood that he was transfusion to his own patient. I mean, what kind of beautiful feedback is that? So we have to, as blood collection organizations and as the Red Cross, we have to do a better job getting that information out and engaging the community to be able to support that messaging amongst each other. So that messaging should not just come from the American Red Cross. That should be a message that the community can send to each other, is that blood donation is important because most of the people in this country that have sickle cell disease are African American, and we need to be there to support our community members and our neighbors by donating this valuable resource to save and support their lives. And Dr. Mack, do you have anything to offer?
Yeah, I think I agree with everything you mentioned. I would just add that undoubtedly things like the Tuskegee experiment and the Henrietta Lack story definitely has contributed to a level of distrust in the African American community. And that lends itself to maybe viewing things through a different prism in terms of physicians and providers going out into the community. I also think it's critically important for providers to look like the patients who they serve. There's undoubtedly a connection that can be reached, not always, and doesn't have to be, but there definitely is a connection between, I think, an African-American physician, nurse, physician assistant who goes out into the community and is actually representing their community and enlisting the community to engage and donate blood for children who also are of African descent. And so I think it's not just incumbent upon us as African American providers, but it's really incumbent on us all to help each other out. Sickle cell patients are contributing members of society, just like anyone else. And so we need to do right by them by helping them achieve longer lifespans and optimal products for transfusions, just like we do children who have other diseases and adults who have other diseases. So I think some of the historical challenges have created some hurdles. I think we're making progress, and I think there's probably more progress to be made. But I think you know, it's about moving the ball down the field, getting a first down, and heading towards the end zone. And I think we're doing that.
And again, you know, patients like Ms. Newsome, you know, sharing their stories, and of triumph and of, you know, their challenges is really what touches people's hearts and minds and communicates better than any physician or healthcare provider could do, you know, how the donation of blood and the transfusion of blood really, you know, supports and saves their lives and helps them live their most productive and healthiest lives. So thank you again, Ms. Newsome.
So we have more questions that have come through the chat box. And if you have some, I would encourage you to put that into the group chat now. These are going to be directed more toward Dr. Mack. And I'm going to take a couple of them in a group because I think that you can probably speak to them as a whole. The first one is, does a donor need just one S gene, or do they need to have both S genes? And then the second question goes, why are the Duffy antigens not required for screening? Or requested or screened for, rather, I'm sorry. Why are the Duffy antigens not requested or screened for?
So good questions. So for our sickle cell patients who have two S alleles, when we are recruiting people to donate blood and when they are transfused blood, we try to give them blood that is not from a person who has sickle cell trait, because they have predominantly sickle hemoglobin. And so we prefer to give blood from a patient who's got normal hemoglobin, just to optimize the utility of the transfusion for those patients. We modeled our program after the program in Philadelphia, and one of the things that they told us they wished we did was that we went out into the community and recruited donors and let them know that there would be an opportunity by participating in the blood donor program to identify whether or not they are trait positive, which is really important because there are some people who have been born before the era of newborn screening who may not know their trait status. So the goal is to donate blood, have donated blood from people who have normal hemoglobin for sickle cell patients. If donors have sickle cell trait and know that they have trait, that blood can go to the general donor pool. And if people who don't know their trait status, with our unique program here in Chicago, in partnership with the Red Cross, they will be tested to determine if they have trait. And then of course, if you're gonna do the testing, you have to provide counseling, and so we do that. I can speak briefly about the Duffy A, Duffy B piece, and I'll also maybe ask Dr. Miller to chime in on what her thoughts are. The long and short is that if I'm O positive, so that means I do not have the A and B antigens on my red cell, and the positive piece refers to an antigen called the D antigen. And so ideally I would get blood from someone who is also O positive, but there are many minor antigens or proteins on the red cell membrane for which, for patients who are serially transfused, who are chronically transfused, or get frequent intermittent transfusions, the fact that they're discordant with some of those minor antigens could predispose the patient who's receiving frequent transfusions to develop antibodies against those antigens. For example, if I'm O positive and let's say I have minor antigen X, and the donor is O positive and they have minor antigen Y. And if I am the patient who has minor antigen X and I need blood every single month, and I get blood from largely Caucasian donors who have minor antigen Y, I will make antibodies against that Y protein if I continually get blood from donors who have that minor antigen Y. It's expensive to do testing at the level of the minor antigens. I think we're making progress there. There's an opportunity to do genotyping and maybe more optimally match blood. And so I think that time is coming. I think the brief answer to the question is it may be expertise related and also expense related in terms of matching red cells between donors and patients at the minor antigen locus. I don't know if Dr. Miller, you have anything else to add there?
Yes, thank you, Dr. Mack. So there is a registry called the American Rare Donor Registry. And so in that registry, we will test when a donor comes in to donate, if they meet, if they're sickle trait negative, which is, as Dr. Mack said, a donor with sickle trait is definitely acceptable to donate. But when clinicians are ordering blood for patients with sickle cell disease, they want a unit that's sickle trait negative, just for the reasons that Dr. Mack indicated. So we do perform extended, as Dr. Mack mentioned, phenotype on red blood cells, so that we can store them in this rare donor registry. So that, and Duffy, A negative, B negative are one of the antigens that we test for, as well as a whole host of others that are more common in African Americans. And so, as he mentioned, this testing, the most sensitive type of testing to identify these antigens is molecular testing, which is extremely expensive. And so we can't test every single unit. So we have to test a certain percentage of these units once they meet a certain phenotype profile. So we're getting there. Molecular testing is becoming, like everything, the more you do it, it becomes less and less expensive. So we're going to get to the point where we're going to be able to routinely test those units where the donor identifies themselves as African American. We test units for people that identify as African American, mixed race, and prefer not to answer. And so that's the group that we initially test for these specific antigens and reserve those units in the rare donor registry, so that when a clinician wants this unit for a patient with sickle cell disease, we can just type in the recipient's phenotype protocol and it will match that unit that we have in that repository. So we do test, and the American Society of Hematology has in December, released sort of its new thinking about how to better match patients with sickle cell disease and what the best profile that we should look at in terms of matching the sickle cell patients. So there's a lot of work being done for us to be able to match those patients closely to prevent the complications of transfusions, and certainly the complications of their disease.
And this is a follow-up question, Dr. Miller. You had just made a remark about the biracial child. We have a question in the chat box. How does or can sickle cell disease affect the biracial child?
Well, again, as we've already mentioned, sickle cell trait is based on a person's parentage. So if a child has a parent of different races, if one of those parents has sickle trait, then that parent can pass trait on to their offspring. And again, as already mentioned, people from all races have sickle cell disease and have sickle cell trait. Again, it's based on the areas of the world where malaria is endemic. So people from all races live in malaria endemic areas all over the world. So if your heritage is from one of those areas, then you're likely to have, you may, again, have the sickle cell trait. So that's why it's important. So every child born in the United States since 2006, have been tested for sickle trait. So they don't just look at the parentage to determine who they test, because you don't know. Because some people might think, a Caucasian person will not have sickle trait. Well, there's plenty of people who designate themselves as Caucasian that have sickle trait. So you can't just go based on race. That's why it's mandatory that all newborns in this country that are born be tested for sickle trait. So everybody has the opportunity to know, what their health history is.
For Robin, kind of quick question. What do you do to kind of keep yourself healthy? And what would you do or say to Black donors to encourage them to donate?
Pretty much what I do is, first, I keep God first. I stay hydrated. I try to keep my weight. I don't do a good job sometimes, but I keep my appointments like every 6 months unless there's something going on, and I'll go sooner. I will go sooner. I've learned my triggers. Excuse me. I've learned my triggers, and I try to stay away from them. Stress, it's kind of hard, but stress is a major trigger for me. cold weather, which is also hard because we're living in Chicago. So I just try to stay hydrated during those times and stay warm and things like that. If I, like I said before, if I can say anything as far as the blood donations, is needed. It's very prevalent. It's needed in the community, and it can help a lot of people. It can save many, many lives.
How has COVID-19 affected patients with sickle cell disease?
Is that for me?
For any of you, for you, Robin, how has COVID-19 affected your ability to receive blood and treatment?
Actually, I was in the hospital twice this year, once in March and once in July for 10 days. And I received transfusion for both times. So it didn't pretty much affect me, but I'm sure that it has affected a lot of other people.
Yeah, so it's a good question. So COVID-19 definitely has created some challenges with respect to blood donation. And the Red Cross has done a good job at making sure that it's safe to donate blood. In Illinois, there was essentially a shout out by the governor and I think maybe the mayor to encourage people to get out and donate blood. And I think the Red Cross has done a good job at making sure it's safe for people to donate blood. And so we've really, I think, had a lot of people step up, and that's a good thing. I think the need will continue throughout the year, especially during the winter, when respiratory infections uptick and hospitalizations tend to uptick. And so the need is going to be ongoing. I'm going to donate blood 8 days from now, and then I'm going to donate blood at the Greater Chicago Blood Drive in January. And as it relates to COVID and sickle cell disease, the major issues with COVID from a hematologic standpoint, so from a blood standpoint, are patients who develop a coagulopathy, meaning they're at increased risk for having problems with the coagulation system, and clotting. And so far, we haven't seen any adverse outcomes specifically because of sickle cell disease. Now, having said that, I encourage my patients to wear their mask indoors.
Mm-hmm.
I encourage them to wear a mask outdoors. I encourage them to keep the mask over the bridge of the nose, to not play with the mask. Because certainly getting COVID is bad overall. I can't say definitively that it makes sickle cell disease any worse, but I could make the argument it could, given some of the problems that we've seen from a hematologic standpoint, which is a coagulopathy and increased risk for clotting. In essence, the vessels become very inflamed, and that can lead to problems with developing clots with COVID-19. And you could certainly make the argument that patients who have sickle cell disease, who have sickling inside of those same blood vessels, who are also at risk for clotting, probably would be good for them to not get COVID. And so for any myriad of reasons, social distancing, wearing masks, washing hands are critically important. I mentioned to my patients that social distancing doesn't mean social isolation. You can still pick up the phone, you can still call people, you can still FaceTime, you can get together outdoors with a mask, 6 to 12 feet apart. So those are some general principles that I implement.
I do see a question in the chat, and someone is asking about what is Red Cross doing to keep people safe when they come to donate. So since the beginning of the pandemic, and I already mentioned this, that we do not take walk-in donors anymore. You have to have an appointment. And when you present to the collection site, before you can enter to the collection site, you have to have, everybody, both the staff and the donors have to wear a mask. And if someone presents to the collection site and does not have a mask, we will offer them a mask. And if a donor presents and says that, they want to donate, but they can't wear a mask, then we ask them to please reschedule and come back. We do not allow people into the collection site without a mask. It has gotten sort of